CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
Good afternoon, everyone. Welcome to our WIP presentation for today from Dr. Farinaz Havaei. My name is Amy Salmon. I am the Associate Director of the Center for Health Evaluation and Outcome Sciences. Before we begin, I'd like to acknowledge with gratitude that our presentation today and the work that's being described is taking place on the traditional, ancestral, and unceded territory of the Squamish, Musqueam, and Tsleil-Waututh First Nations. So today's presentation is from a recently appointed CHÉOS scientist who we're delighted to have sharing her work with us today. Dr. Farinaz Havaei is a health system researcher with a passion for improving the quality and safety of healthcare services across the healthcare spectrum, particularly in the long-term care sector. Given the critical role that nurses play in ensuring their patients' health and safety, her research studies and addresses those system-level factors, for example, those at the unit level, the organizational level, and at the policy level, that improve workplace psychological health and safety of nurses, and subsequently their ability to deliver effective patient care. Dr. Havaei's research has been funded from a variety of local, provincial, and national funding agencies, and to be speaking with us today on an introduction to the synergy tool implementation in long-term care, which has been funded by the Canadian Institutes of Health Research. Please join me in welcoming Naz.
Excellent. Thank you so much, Amy, for this really lovely introduction. And as you also alluded to, this project that I'll be presenting today, it's been funded by the Canadian Institute of Health Research, and we actually do have several CHÉOS members and scientists, including you, Amy, and a few others, being co-investigators with me on this project. So I'm really, really grateful for the opportunity to be able to work with those of you who have been involved in this project. Before we start, I'd like to also acknowledge that I'm coming to you from UBC, which is actually located on the traditional, ancestral, and unceded territory of the Musqueam people. So in terms of our agenda, what we're going to sort of start with are the knowledge gaps that essentially yielded or resulted in this project, and the goals that we were really hoping to accomplish with the study. We're going to sort of introduce this tool, or I guess this intervention, that is related to workload management that we essentially implemented as part of this project, and then the methods that we use for implementation of this intervention in long-term care, and also the methods that we use for the purpose of evaluation. Although we're only going to be, or I will be only sharing some preliminary results with you, just because we are still in the process of data analysis. And so our results at this point, a disclaimer is that they are essentially preliminary results at this point. So just in terms of context, our research during the pandemic, our earlier research, and also research conducted by other researchers in Canada, essentially have highlighted how long-term care delivery before and during the COVID pandemic, how it was significantly compromised due to heavy workloads. And, you know, when the pandemic happened, with the pandemic management policies that were implemented, like the one high-risk site order, the strict visitation policies, the strict infection prevention and control requirements, all of those policies and practices, they essentially work together to exacerbate existing, or I guess, workload challenges that existed in the long-term care sector prior to the pandemic. And so just to bring all of us on the same page, persistent workforce challenges in the long-term care sector include, first of all, lack of appropriate nurse and personal support worker staffing levels to ensure safe, quality resident care, inadequately trained healthcare providers to meet the demands of an increasingly acute and complex long-term care resident population, deterioration of psychological health and safety of healthcare providers, so our personal support workers, nursing staff, so on and so forth. And finally, attrition and a turnover of nursing staff and personal support workers from this sector, the long-term care sector, due to really suboptimal or poor working conditions. So all of these factors sort of work together to result in really heavy workloads and I would say work overload for the providers that then resulted in sort of compromising the quality of care delivery to residents, long-term care residents, and also deterioration of psychological health and safety for workers. So under these circumstances, we all know that staffing decisions in this sector are essentially based on arbitrary standards and economic needs, as well as availability of resources, so both human resources and material or financial resources, as opposed to resident needs. I can give you an example that I do hope it sort of better justifies why I'm saying this. And that example is essentially the hours per resident day, the HPRD. Nobody really knows where that recommended HPRD number, where that comes from, and if it's actually data-driven or informed by the needs of the long-term care resident population. I have looked for like research papers, research studies, and I honestly haven't been able to find any Canadian studies that provide justification for the recommended HPRD in British Columbia and also in other jurisdictions in Canada. So the goal of this project was to improve resident, informal caregiver, healthcare provider, and long-term care home outcomes by adapting, validating, implementing, and evaluating an evidence-based, resident-centered model of care delivery known as the Synergy tool. And the Synergy tool really, it's a resident needs assessment tool that aims to understand and operationalize the acuity and dependency needs of clients, patients, and residents. And the reason I'm saying clients, patients, and residents, and the reason that the focus is actually on adaptation of the tool is because the tool, like we had actually worked with it quite a bit in Canada, in other sectors, so in acute care, and I'll talk a little bit more about that later on. But again, the Synergy tool is a patient needs assessment tool. It looks at 8 patient characteristics. 5 of them are acuity and 3 of them are dependency characteristics, and I'll go into details in a little bit in regards to what those characteristics are. But overall, as I said, we had successfully implemented the tool in a variety of healthcare settings and sectors, including in BC Women's and Children's Hospital, and Kelowna Cancer Agency, and that's back in 2018. And then more recently, in I believe 2022, we actually implemented the Synergy tool in 4 surgical areas in Royal Columbian Hospital. And I mean, there are also other settings and specialties that have utilized or adapted or implemented the Synergy tool. And one of those areas is actually emergency departments. And again, I'll be talking more about that in a few minutes. So the Synergy model, I'm going to just give you some sort of a background or historical origin of the Synergy tool / Synergy model. And I'm just sort of noting that I'll be using these terms interchangeably. Synergy tool is actually one component of the Synergy model, but for the purpose of today's presentation, I'll be using both of these terms interchangeably. So really, the Synergy model started from the critical care specialty, and it's based on the dissertation work of Dr. Martha Curley back in, I think, 1997. And her research focus was actually on improving nurse-patient relationships through providing critical care nurses with better tools to assess patient status and risk. And she actually, Dr. Curley, advocated for nurse competencies that are driven by the needs of patients and their families, which essentially resulted in the synergy model. So as I said, the synergy model is really the work of Dr. Curley, and in a way, it was a rebellion against time motion studies and classification of nurses by task. A lot of research up to that point was looking at nursing work, nursing workload by doing time motion studies, by looking at the number of tasks that nurses completed, as opposed to looking at nurses' competencies. And so the underpinning philosophy of the tool or the model was that a fit between patient characteristics or patient needs and nursing competencies would actually result in positive outcomes and best outcomes for patients. And so the synergy model or the synergy tool actually, it looks at 8 patient characteristics and rates them on a scale of low to high needs. The 8 patient characteristics are, as you can see, complexity, stability, vulnerability, predictability, resiliency, participation in decision-making, participation in care, and resource availability. So these are the 8 characteristics that the synergy tool essentially looks at. And these characteristics are then sort of classified into 2 domains of patient acuity and patient dependency. And how the tool is utilized is that care providers, especially nursing providers, they are actually supposed to rate each of the patients on each of these 8 characteristics and determine how they score, whether they're high needs, moderate needs, low needs, so on and so forth. And I would say overall, the rating scale, and one of the really good things about the synergy tool or this intervention is that it's a very participatory intervention in that nursing providers and interdisciplinary care providers, they have a say in first of all, developing the tool and also developing the rating scale. So it's actually the expert providers who decide, as an example, if they want to be going with a 5-point scale versus a 3-point rating scale, if they want to sort of do higher scores as higher needs versus lower scores as higher needs. So there are these variations, and depending on what works for each context, each specialty, or each patient population, the tool could be, it could be adapted. And we've actually worked with some partners who have used a 5-point scale because that was what was working for them, and then others that wanted a 3-point scale. And then again, some partners used like the 4s and 5s as high needs, and then others who actually did it the other way around, where 1s and 2s were high needs. And typically, a score of 3 on the tool, it essentially refers to a patient who has moderate needs, or when you actually do not have enough information, or you don't know which way the patient will go. Maybe because you don't have all the information you need, or you're still waiting for test results, or with some diagnosis, the prognosis is just unknown. The patient could go like either way, right? They could go up, they could go down. So as indicated earlier, patient characteristics are really like they form these 2 domains of acuity and dependency, or in some places we refer to it as capability characteristics. And there are underlying definitions for each of these characteristics. So as an example, stability refers to the extent to which patients are able to maintain a steady state and have vital signs that do not change, right? Complexity is about like the number of systems that are involved in a patient condition. If you have multi-systems involvement, that's a highly complex or high needs in relation to complexity patient. Predictability is regarding illness trajectory and whether it's expected or unexpected. Resiliency is about a patient's capacity to return to baseline. Vulnerability is around risk of complications and harm. Participation in care is essentially about the extent to which patients can take part in activities of daily living, and participation in decision-making, the extent to which patients essentially have the cognitive or even the physical capacity to take part in decisions regarding their care. And resource availability, I would say, is about resources available to the patients. And I would say that's perhaps in relation to social determinants of health, things like housing and social connections and income, so on and so forth. And so assuming this is a patient example, and I just want to sort of introduce you to how the tool can be used. And so assuming this patient example, you can essentially apply the synergy tool to this patient or case scenario to determine the extent of this patient's acuity and dependency needs. And I'll let you read the case on your own. I'll just give you a few seconds. So this is the case of a 64-year-old female coming to contact with our healthcare system. And these are some of the conditions and signs and symptoms that they're experiencing. And so really, when we applied the synergy tool to this case, you can see that this scores that the case or the patient in this case scenario received. And so in this case, we actually use the reverse rating scale where 1s and 2s are high needs and 4s and 5s are low needs. And it seems like that we use a 5-point scale because, I mean, there are 1s and 2s and 3s, but the patient doesn't seem to have any 4s and 5s. And I'm just gonna use one of the characteristics as an example to sort of walk you through how the scoring was done. Because the vital signs are quite labile, if you go back to the case, because there is blood loss and because the patient is unconscious at times, it essentially spoke to the patient being really unstable and being high needs in relation to stability. And so as a result of that, then they are essentially receiving a score of 1 for stability. And so we use the similar process with respect to this case, just looking at the information and looking at our synergy tool to then decide how the patient scores and where they stand in relation to their needs levels for each of these characteristics. And so I just want to sort of mention that you guys have not seen the tool yet. I'll be showing you the synergy tool that we adapted for the long-term care sector in a little bit. But essentially, there are indicators for each of the characteristics. There are indicators for the high needs, for the moderate needs, and for the low needs. And the scorers or the care providers applying the tool, they look at the synergy tool, they look at the patient characteristics, conditions, and compare it to the indicators. And based on the indicators, then they decide where the patient falls in relation to needs levels for each of those 8 characteristics, if that makes sense. So this is the patient rating tool that providers use to assess the patients using the synergy tool. And you can again customize this depending on what works best for your patient population and your context in terms of the rating scale, in terms of how the scoring is done, whether high needs is high scores, low needs is high scores. So you have a lot of choice as the providers and the frontline experts to determine how the rating tool and how the tool actually is customized and adapted for your context. So contrary to the last case where high needs were 1s and 2s, here you can see that the high needs patients are actually 4s and 5s. And some units put the rating tool into the patient Cardex. Others have incorporated into their electronic system. And a few of our partners have just used Excel sheets to do their scoring. Some places we've essentially developed a separate electronic data collection form for them to go in, enter their numbers, and the system would then automatically generate acuity scores and unit level acuity and dependency scores for them at any point in time. So this essentially is saying that there are really different approaches to how the tool is adapted and how it is implemented. So as I've been saying, the tool is one of the great things about the tool is that it's adaptable. You can really customize it to different contexts. And another really important strength about the Synergy tool is that it could be used in real time to gain an understanding of the patient needs and to inform decisions regarding, staffing assignments and workload distribution, and how you or which nursing provider or which healthcare provider can best care or meet the needs of a particular patient. So, and some of the work that we've done, our participants, as an example, have spoken to how the Synergy scores were used to inform where the float nurse would be working, where they would just have a float nurse and then they would use the Synergy scores to determine, okay, this is the area or this is the unit that is going to benefit from having the float nurse at like this morning shift, so on and so forth. The Synergy tool also could be used for communications, regarding patients and their needs, during handover, a transfer, a shift-to-shift report, during interdisciplinary rounds, and also for the purpose of care planning. It really, it provides a communication framework in a systematic way for care providers to talk about and discuss patient needs. So in terms of using the Synergy scores to inform staffing, in one of our earlier projects in Abbotsford Regional Hospital in the critical care unit, the team actually agreed that each patient would be scored once a shift, and in this case, lower numbers were associated with higher care needs. So if a patient was scored as 1 or 2 or high needs, the team essentially agreed that they would require a registered nurse to care for them with ratios of 1 registered nurse per 2 patients. I'm not going to get into all of these like agreed upon staffing guidelines, but just introduce the notion of the Synergy tool being perceived as a workload management tool, because the expert providers, the nursing providers, and also other interdisciplinary providers can use the scores to inform decisions regarding staffing levels, so how many staff, regarding skill mix, what type of staff, is it a registered nurse, is it a licensed practical nurse, is it a social worker, and also in relation to creating patient assignments and matching the care provider's competencies with the patient needs. And in terms of other potential uses of the Synergy scores, you can really create, when you apply the Synergy tool, you can use the scores to create patient population profiles for various specialties or areas. And you can also look at the variability in patient needs over time. And you can do that for, looking at seasonal variation, and also use it for forecasting purposes to determine your staffing needs based on your patient population, acuity, and dependency needs. And so, as I said earlier, there is quite a bit of work done on the Synergy tool. There's a systematic review conducted by Nanya back in 2021 that essentially linked the use of the tool to positive outcomes for patients, providers, and organizations. So really what this is saying is that this synergy tool is very much evidence-based. But one limitation that this systematic review essentially pointed out was that most of this work up to this point, up to 2021, was conducted in acute care or community care settings. And so, as I said, the tool, we had used it several times in multiple specialties in acute care settings. And it actually in BC, it started, the tool was introduced and piloted years ago in 8 practice sites in acute, community, and mental health units. But unfortunately, at that time, the work really didn't go anywhere because of some resistance and that we experienced from decision makers in terms of, the subjective nature of scoring and some concerns about nurses playing the scores and the system to get extra staff, which is really unfortunate because, nurses are the ones that are in charge of doing all of these patient assessments. And so it's really unfortunate that at that time, their perceptions and their scoring in relation to the synergy tool was not trusted. But that work, the synergy tool it had a comeback back in 2018, where myself and my colleague, Dr. Maura McFee, who's also a co-investigator in this project, we introduced the tool to 3 PHSA sites in BC Women's and Children's Hospital and also Kelowna Cancer Agency, and then more recently in 4 surgical areas in Royal Columbian Hospital. And the tool has been also implemented in other Canadian provinces like Saskatchewan and Ontario. And in Saskatchewan, we actually had 1 emergency department that participated. And I believe the results of that work, they're published, they're papers that we, or I guess Maura and others, I wasn't a part of that project, but there are published papers from that work if you want to look it up. So up to this point, I've been just giving you a general overview of the synergy tool. But from this point onward, I'll just sort of talk more about the project that we've been doing over the last year, and I will just sort of provide more specific details regarding our project. So in terms of our project, we essentially used a mixed method study with 3 phases in 2 publicly funded long-term care homes in Lower Mainland British Columbia. And so this slide, I don't expect you to look at all of the details, but it's just essentially a process map of our project in terms of our objectives and goals and research questions for each of the 3 phases of the project. And so I've sort of broken down the key steps and key activities for each of the phases on this slide. And I would say with respect to the first phase, really the goal was to train staff to work together to develop an adapted version of the synergy tool for long-term care, to make sure that the staff, they were adequately trained and educated in terms of using the tool, and then also to work together to collaboratively develop an implementation plan and a set of staffing guidelines that would go with the synergy scores. And to do that, we essentially had a 1.5 training workshop where we did all of these things, and I'll talk more about that in a little bit. In the second phase really was about implementation of the synergy tool, or using the tool to score residents. And our team essentially during our training workshop, we agreed that the scoring was going to be done at least once a week for 6 months. And then second phase was also, it involved quantitative evaluation, where we did a longitudinal survey of staff, so pre and post, as well as longitudinal survey of informal caregivers, so family members. And we also looked at the trend over time in some administrative data on a monthly basis. So again, before and during the implementation phase. And our phase 3 involved a qualitative evaluation where we conducted focus groups with staff members, families, leaders and managers, residents, regarding, first of all, barriers and facilitators that care providers and care homes sort of encountered with respect to implementation, and also the impact on their resident care delivery. So as I said, the first phase of the project was really about training and also planning for the implementation. And so we had a day-and-a-half training workshop that was offered virtually, with both of our partner care homes participating or joining the training workshop at the same time. And we had about 8 to 10 interdisciplinary care providers join the training workshop from each care home, 2 to 3 leaders and managers. And it was also really important for us to make sure that family and resident voice was included in this early phase, because it really had an impact, an important or a huge impact on the type of tool and the type of indicators that would be developed for the long-term care sector that would essentially speak to the needs of the residents. So we had about 1 to 2 residents and or family representatives from each care home also join our training workshop. And in relation to the care providers, a lot of our work up to this point was done with nursing providers only. But in this project, we actually expanded our workshop participants to an interdisciplinary care provider, social workers, physiotherapists, so on and so forth, dietitian. They were also invited to participate and were a part of our training workshop. And really, as I said, this was the very first time that the Synergy tool was being implemented in long-term care. So it was really important that the tool was appropriate and relevant to this context and to the needs of the resident population. So a lot of our work in the training workshop really involved adapting indicators for each of the 8 characteristics that were appropriate for the long-term care resident population. We had our participants to ensure that our training was effective and to ensure that we actually had a good tool available to us. We actually had the workshop participants practice scoring on a number of case vignettes, and then we actually evaluated inter-rater reliability. And then part of our training workshop, I believe our second day, was actually spent on co-developing or collaborating with the participants to develop an implementation plan and staffing guidelines that would go with the Synergy scores. So this is essentially an adapted version of the Synergy tool for the long-term care sector. And I don't really expect you to see all the content, but as I explained earlier, what I want you to really see here is that, these are on the top, you can see your 8 patient or resident characteristics, from stability to resource availability. On the rows, or the purple, is where you have your needs level. So high needs, the team decided that was going to be a 5, and they actually wanted to use a 3-point rating scale. So high needs would be a 5, moderate needs would be a 3, and low needs would be a 1. And then you can see that there are definitions and indicators for each of the characteristics. So as an example, the team defined that for this population, stability or being high needs in relation to stability is where you have rapid or substantial change in physical status. And some examples of patients who would have that, or who would have that condition, would be those who are either actively dying or delirious or experiencing seizure or have had a fall with a head injury within the last 72 hours, so on and so forth. So just, I hope this provides some sort of clarification in regards to how the adapted version of the Synergy tool or Synergy tool in general is used to do scoring. So the care providers will be looking at these indicators to determine where the patient fits the best in relation to the each of the characteristics, whether they're high needs, moderate needs, or low needs. We also co-developed an implementation plan with the workshop participants in terms of what we had agreed upon regarding the frequency of scoring, the start and end date, the method of data collection, and who will be doing the scoring, and so on and so forth. Again, I don't expect you to read all of these details, but essentially what I want to show is that we really made sure that the frontline experts, that the care providers were a part of our conversations and discussions regarding implementation. And we actually, after our training workshop, we essentially sent a copy of the implementation plan to each of our partner care homes, just as a way to create some accountability. And also just because we know that everybody's so busy, workload is really heavy. So we wanted them to have all of this information, readily available to them, when it was time for them to start with the implementation process. And these are the staffing guidelines that we developed. And during our training workshop, we were really fortunate because we actually had an HR director who was able to participate in our training workshop. And he actually really helped guide discussions regarding staffing guidelines for Synergy score. So in collaboration with the care providers, leaders and managers, including the HR director, these are the staffing guidelines that the team developed. And, they essentially said for various patient or resident profiles, what would be an ideal or optimal way to staff, both in terms of staffing levels as well as skill mix, so the type of staff. And so at this point, I'll be sharing some preliminary quantitative results with you. And here you can essentially see the trends in Synergy scores in the 4 participating units across the 2 partner care homes. And the top graph is the acuity, and the bottom graph is essentially the resident dependency scores. And what you're seeing here is really during our implementation. So remember how I said that the team essentially agreed to use the Synergy tool at least once a week for 5 to 6 months. And these are the scores that they entered at a unit level during that time period, so implementation week. And really what's most interesting to me, I would say, is that you're seeing that there is actually some variation in resident needs, especially I would say the greatest levels of variation is in unit A1 and unit B2, right? So what's really interesting from my perspective is that even though there is this myth out there that resident needs are relatively stable over time because it's not an acute care setting, because it's not a hospital setting, you can actually, our data actually shows that certainly that is not the case, especially for unit A1 and unit B2, right? So there is quite a bit of variability in terms of acuity and dependency needs. We also looked at overtime trends for 12 months before and 5 to 6 months of the implementation phase. And the dark blue or the solid blue line shows that we actually saw a drop. So this is prior to implementation and this is during. And you can see that there is a drop at least immediately during the implementation phase. That said, unfortunately, we're actually seeing that the rate starts going back up to its original place, during later months and later weeks of the implementation. But what's really interesting and something that we're actually hoping to be able to navigate further is that we're actually seeing that one of the units in particular has this really a significant spike in terms of overtime rates. And we're wondering what happens to our average or this sort of average line across the 4 units if we take the data from this unit out. And we've actually had some conversation with the leaders of that particular care home to see what's been happening. And, it seems like they were really experiencing some issues in relation to workload and in relation to some of the residents being very sick, and they had to actually bring in extra staff to respond to these increasing resident needs. And actually, if I go back to this slide, you can see that unit A1 is one of the units that's actually showing that variation in acuity and dependency. And unit A1 is the one that is experiencing the spike, the significant spike in overtime rates. In terms of resident falls trends, we're similarly, we're seeing a decline, both in terms of average, so there's a drop immediately after, and I would say, but also in terms of the rate. So you can see that the line starts plateauing, which is really, it's a desirable finding for our project. And in terms of our survey data, I don't really have much to report because we're still in the process of data cleaning. So unfortunately, I don't have much to report in relation to that. And there will be hopefully more findings in relation to the survey data from staff and family members over the next couple of months. So we'll have to revisit that aspect of the project. In terms of focus groups, so we ended up actually having 6 to 8 participants from each of the groups across both of the care homes, from the staff group, leaders and managers and families. Unfortunately, we were not successful in terms of recruiting the residents for our project due to high rates and prevalence of cognitive impairment. And so we actually relied on families' perceptions and reports of resident care delivery. And what we found was that really the synergy tool had some positive impacts on resident care delivery. It essentially improved resident care delivery in long-term care. And some specific ways that the synergy tool improved care delivery was by raising providers' awareness regarding resident needs, by helping them detect subtle changes in resident status from the baseline, by facilitating teamwork and communication among providers, by even facilitating communication with family members, providers' communication with family members, and also helping care providers to think more proactively and planning resident care more proactively. And I do actually have a few quotations here. This one is from a licensed practical nurse, and I think it really nicely speaks to some of these positive impacts that I just summarized for you, particularly around raising awareness regarding resident needs and also detection of subtle changes. I'll let you read this quotation on your own for a few seconds. From my perspective, it's a really impactful quotation. Okay. And then what's even more impactful is this quotation from a family member who actually worked with Sarah, the LPN, whose quotation you just saw. And these are pseudonyms. just because we want to make sure that we maintain anonymity of our participants. But essentially, this quotation from a family member who worked with Sarah and actually recognized that, you know, there were improvements in Sarah's care provision, particularly in relation to being able to detect subtle changes and more proactively respond to changes in this family member's loved one in terms of, you know, changes in their baseline. And I think the consistency between what the nurse is reporting in terms of changes in her care provision, and also what the family is reporting in terms of their observations of this care provider's care delivery, from my perspective, it's really interesting. It makes the evidence in relation to the positive impact of the tool very strong. Again, I'll just give you a few seconds to read this quotation. It's a long one. Okay. All right. So these were the positive impacts. The focus groups data also spoke to barriers and challenges in terms of the synergy tool implementation. One of the most significant barriers was essentially staff members and leaders spoke to how they were essentially unable to implement the staffing guidelines that they had developed to that they developed during phase 1, and that would go with the synergy scores because of resource inadequacies, right? They essentially talked about how they had these set HPRD, hours per resident per day, that was funded, and that they could not really go over that, right? So, and that was a significant challenge that they encountered. And rather than you know, using the synergy scores to inform their staffing levels, they actually, or even their skill mix, they actually use the scores to inform where the float nurse would go. They use the scores to create resident or staffing assignments, and essentially to create or match nursing competencies with the resident needs, but not for the purpose of staffing levels or skill mix, because those were essentially pretty established and not a lot of room for flexibility. Some participants also talked about how, especially early on, it was challenging to implement and use the synergy scores because of the time that it took to score residents. And, you know, the average time that they reported, at least early on, was between 1 to 2 minutes per resident in terms of scoring. And later that time was a lot, like it was reduced by probably half. So most participants reported, you know, the tool that they were able to essentially implement the tool within 30 seconds to 60 seconds per resident. And then they also talked about, because we essentially use the trainer framework for implementing the intervention, because we couldn't really educate all of the staff because of our limited funding. And so some staff members also talked about how training new staff and staff that were not a part of the training workshop was essentially somewhat time consuming for them. So all of this, some of these preliminary results essentially suggest to us that, you know, the implementation of this intervention, and I think any intervention in general in long-term care should be supported by adequate resources, both human resources as well as financial resources. So I know I probably went over my time, and I'm sorry about that, but I'm just going to end it here and see if there are any questions for me.